We'll be starting with our next session. I would like to call upon on stage our chairpersons, Dr. Arun Prasad, Dr. Rajesh Shah, Dr. Jayanta Muperia, and Dr. Malvika Mishra. A little bit about our chairpersons. Dr. Arun Prasad, gastroenterologist and bariatric surgeon, Apollo Hospital. Dr. Rajesh Shah, President, Walls. Dr. Jayanta Muperia, expert in minimal invasive surgery and laparoscopic surgery. Dr. Malvika Mishra, professor and unit head, Obs and Gynae, RML. She's a laparoscopic surgeon and IVF unit head at RML and secretary IFS. I would now like to call upon our first speaker, Dr. J.S. Prabu Doss. Dr. Prabu Doss has been a guiding force in advancing gastrointestinal endoscopy, and today we are fortunate to witness his invaluable insights on a groundbreaking topic, prospective comparison of conscious nasal versus oral video upper GI endoscopy in adults.
There's a small change in the topic. That's for my talk tomorrow.
Okay.
So the present talk will be on endoscopic sleeve gastroplasty. With the permission of the chair, can I start the session, sir? Sir, can I start? Yes. Good evening, and my special thanks to Professor R.K. Mishra sir for inviting me and giving me a sudden topic on the 11th hour. But anyway, I was prepared for this. I spoke to Dr. Bala already, and he has already laid all the foundation and convinced the entire audience to prove that a surgeon should be a good trained endoscopic as well. I am a surgical gastroenterologist by qualification, and I have chosen my career to be an endoscopic bariatric surgeon. So I do much of my endoscopic sleeve gastroplastic surgeries. And at the background, the endoscopic sleeve gastroplasty. It is as simple as this. We all know the laparoscopic sleeve gastrectomy, where laparoscopically the surgeon enters, divides the stomach, and the part of the stomach is removed. Because the remaining stomach remains like a sleeve, that's called a laparoscopic sleeve gastrectomy, which means a part of the stomach is removed. Whereas in endoscopic sleeve gastroplasty, by endoscope, it's a special endoscope, it's a dual channel endoscope. I'll be showing the video of the endoscope as well. I enter the endoscope, and through the dual channel, sutures are taken inside the stomach, whereby minimizing the capacity of the stomach, almost giving an 80% result of a laparoscopic sleeve gastrectomy, and the results are also very promising. It's a full thickness bite, and it's a technically very challenging one, but still with training nothing is difficult, and as far as the surgical training goes. Can you play this video? Yeah. See, this is an animated video from the Apollo Endosutures. They are the pioneer company who started this. Now the company has been taken over by one more company. See, you can see from outside view, this is how the entire stomach is reconstructed by endoscopically. And now this is an endoluminal view, where the endoscopy goes inside the stomach and sutures are taken. From the, if you see your side, on your right is a lesser curvature, on your left is on your right is a lesser, and left is your greater curvature, and you suture up to down, taking the entire greater curvature, because that's a part of the stomach, that distance after taking food. So you minimize that distension and you slowly narrow the lumen, but still the lumen of the entire stomach is maintained, and you take sequential bites. So for a proper endoscopic primary gastroplasty, even about 6 to 7 sutures are needed, and and it may vary according to various stomach as well. And even some of the redo surgeries are being done by our team, where after laparoscopic gastrectomy, when there is a distension of the stomach, and by endoscopically just 1 or 2 sutures will minimize the size of the stomach, whereby it gives a good post-operative weight loss as well. And here this is a very standalone procedure, and it carries a very good advantage than compared to a conventional laparoscopic surgery, because these are candidates who are not a morbid obese patients. We are not there to compare head to head where the laparoscopic sleeve gastrectomy results or a bypass results versus endoscopic sleeve gastroplasty results. It is not like that. These are individuals who has to be chosen from the population who are overweight, who are on class 1 obesity, who require and weight loss to a particular extent, where there will be a reversal of a metabolism. For example, a pre-diabetic group are a very good choosers of this. Primary infertility, since there are so many gynec people in the crowd, primary infertility who wants to lose about 10 to 15 kilos of their weight, they are very good candidates of their particular choice. I'm just telling you who are the people who are chosen for this on a majority, which will be more successful. And third is who are waiting for a knee surgery, where the doctors are advise them about 10% of their body weight to be lost in this particular conservative method. They can be chosen. And by surgeries who have already failed with bariatric, they don't want a resurgery, and this is definitely a good option for them to have a procedure where they can have a good weight loss. Yeah, can you play this slide? This is the original video, and for the want of time, I will just show only the one stitch, after which you will be able to understand the whole stuff again. See, these are the instrumentation that we use. For example, this is the over tube through which the dual channel endoscopy comes. And this is the Apollo endosutury material, where you have to take a suture, and this is a needle exchange catheter, where the needle gets exchanged from one tower to the other tower. Once I explain it, you will be able to understand it better. This is a helix, which is like a needle drive that goes into the tissue, pulls back the tissue, and after that you take a full suture. This is a post-operative picture that I usually make for all the patients, and this is for your little bit easy explanation, where 6 sutures are taken on the greater curvature to minimize the lumen. See, this is how the entire instrumentation looks from the endoscopic view, and this is what you see inside the stomach. And that is the tissue helix that goes into the stomach, makes a full thickness drive. It is like a corkscrew, just screws the entire thickness of the stomach, and it pulls towards the tower. Once it comes inside the tower, the needle with the thread goes through the tissue, and after that the thread gets exchanged and one suture is taken. It is as simple as a conventional surgery, where you hold the tissue with the tissue forceps, take a drive, take the needle out of it, the tissue gets the thread in between. The same technique is used in endoscopy. Only thing is, in endoscopy, the suture drive is on the left side and the tissue exchange happens on the right side. Just wait for the entire video. Once it has a full thickness, you will have to release the tissue, then after that you will be able to take that particular, you will be able to see that suture which has passed through the entire body. Yeah, that's the first suture. And whatever you see the metal, that's the tissue exchange, which does not have it has a needle in that, and after that get back to the tower, the needle comes in, it gets loaded with a thread, the needle goes back. Now the needle is ready to drive, which means you go through the tissue. Again the same process. It's like pedaling of a cycle or a swimming. You don't have to learn every time the technique. It's all 1, 2, 3, 4 steps. Repeat the steps again and again. Only thing is, you have to know which tissue to be taken. It is all taken in the figure of U. For example, you start a stitch like this, go through the lesser curvature, again end up in the same side. Once you end up the entire tissue, the whole tissue is nicely narrowed down as how you make an appendicular loop or any endo loop. Once that loop is formed, the tissue crumbles and it forms a nice chunk of tissue. Then after that, a special instrument called the needle thread cutter comes in, and it cuts the entire tissue and seals the whole thing. So which means the thread is taken through all the tissues, it is ended up in the same area and it is looped. So that's how it makes one stitch. Like that, you follow the folds, the figure of folds, and you keep taking 1, 2, 3, 4 until your fundus. The disadvantage of this particular instrumentation is because it's a dual channel, you cannot go little more. That's the last. Just watch it. That's the last step. That's how you make the. Once that metal goes in, that's it. The tissue gets cut. That's it. That's how the stomach looks like. See, you are able to see the stitched stomach, and on the right side is your pyloric antrum, and this is a fold. You are supposed to minimize the entire fold, which means you have to keep taking the tissue again and again. It's a figure of U. Just keep ripping it. If you don't find one area is not taken, you take a stitch again. Only thing is the cost of a suture and that particular instrument that cuts the suture is a big trick behind it. If people are interested, I will tell it, because you should know what is the cost of the procedure as well. Next slide. Yes. So this was an introduction. It's a new procedure. It's a novel weight loss solutions that is provided as a minimally invasive endoscopically. And why endoscopic sleeve? Because it reduces the size of the stomach. That is what the laparoscopic bariatric surgeons, as we all aim to do it. And this, because it's a full thickness bite. Yes. Because it's a full thickness bite, we are able to achieve the same results of a gastric fast emptying, and the anatomy is not altered because it is not compared to any bypass procedures. And the current status of ASGE is now the level has come where the people are comparing head-to-head laparoscopic sleeve gastrectomy versus endoscopic sleeve gastroplasties, and the results are nearly compromising, and it is also very much appreciated in the endoscopic world congresses that occurred last month in Indore. Advantage of ASGE is it is not a surgical technique, so there is no scars. Excuse me. The patients get back home much faster, and on the day of surgery itself they will be able to take the oral liquids, and after which they should be followed up for 6 months to 1 year, and they really lose a good amount of weight. But only trick of the trade is they have to be on a supportive pharmacotherapy along with this procedure to have a very good results in the post-operative weight loss. The future aspect is ASGE will be combined with other procedures as in hybrid procedures, and the more weight loss and metabolic effects will be achieved. And this is the comparison of the procedures. I'd like to conclude saying that ASGE represents a promising solution for weight loss with several advantages over traditional bariatric surgery. Ongoing researches are happening where it will expand its future to even robotic as well. While ASGE is not for everyone, it offers a very less invasive option with effective results for many patients. Thank you for your patient listening. I am ready to take up questions.
Thank you, Prabu Doss. It was an excellent presentation. Any questions from the house?
Yes, sir. See, actually, that question is already there for any bypass procedures as well. When you do a gastric bypass, you remove the remnant of the stomach and you bypass the entire stomach, and you make it to go through a different channel. So here, pre-operatively, as such, we do a check endoscopy to ensure that there is absolutely normal stomach on visual endoscopy, and after that we suture the entire stomach. It's a full thickness bite, and it involves only the muscularis layer, not the outermost layer. So if at all the patient has to develop a lesion inside the suture stomach, then it's left to the future endoscopy biopsies, and you will have to confirm it. But anyway, it's a hypothetical question. If it comes, it has to come. It has to be managed as well. But this suturing does not anyway give you a chances for malignancy, so don't worry about it.
Congratulations, Dr. Prabu Doss. Your talk was very lucid. So I think this is something very promising for PCOD patients, as you said, because even before ART techniques like IUI and IVF, if there's weight reduction 5 to 10%, it gives significantly better results. What I would want to know is what are the cost, complications, and recurrences? Like how long is it effective, and there's a resumption of weight gain again, and how much time? Like
Actually, thing is, endoscopic procedures are very, very promising as of now, because it gives a good 10% weight loss that you actually aspire to give for a infertility couple. But only thing is the suture and the cinch. That's what we call it, a pair. One suture and a cinch to cut it. The previous cost was 40,000 plus 40,000 is 80,000 per suture.
per suture?
Per suture.
And how many sutures are you taking?
6 sutures as such. So the cost of the procedures would be somewhere around 2 lakhs, 1.5 lakhs to 2 lakhs. The procedure with the instrumentation alone. So probably extra, we actually charge patients about 3 lakh as a package as such. But the only thing is, compared to endoscopic balloon, which is also can be offered as a weight loss choice for the patients. But the tolerability of the endoscopic balloon is not that simple. Patients do not tolerate the balloon very good. But the endoscopic sleeve, we leave the fundus in situ. So the patient has a good fullness, they don't vomit so much, but the procedure per se has some little pain in the first day of post-operative period. After that they settle with that. But only thing is, it's an irreversible procedure. Like once it is taken, it is done. So the entire stomach is only of that particular size. But if at all they have to eat, they can still eat. Not like laparoscopic sleeve gastrectomy, where they eat, they vomit. It is not like that. In endoscopic sleeves, they will be able to little eat, and they will be able to have some little fullness as well. And as you said, the disadvantage or complication is the suture gives way, then after that the stomach expands again. I don't say that all sutures will give way. Even if one suture gives, that's a space inside stomach. And we go in after 3 months or 2 months, we resuture the whole stomach, if the patient is willing to pay for it.
Thank you, Dr. Prabu Doss.
Sir? Yeah, sir, that's the instrument, whatever I showed, except for the sutures and the cinch, which goes with the patient. Other thing all is reusable. No, I'm just telling you, in spite of that, the suture and the cinch doesn't give away. 40,000 plus 40,000 is what the patient has to pay. But ideally, as how we use it for all procedures, it is supposed to be a one-time usage. But because we are able to sterilize it and we are able to take it safely to the next patient, we can reuse the same. Endoscopies as such, it's no problem. It's a dual channel endoscope. It is a special endoscope. So it is not a regular endoscope. So you cannot attach any instrumentation. So it's a dual channel, has to be invested separately in your endoscopic armamentarium. And only thing is, there are very few procedures to do in a dual channel. So it is not that you buy a dual channel and you can do some other procedures. It's the same side. It's about 8 lakhs. 8 lakhs. It is available with Olympus, it's available with Fijinon, it's available with Pentax. All companies give you. And the boxes is all the same. Only the endoscope has to be attached. So there is no special instrumentation. The endoscopic cost alone is about 7-8 lakhs. It's the same for any colonoscopy or upper GI endoscopy.
Thank you very much.